We have to hurry up a bit. We come to our next speaker. This is Professor Hans Hirsch. He is medical doctor and professor of virology, specialized in HIV and other viruses. He is the director of the Division of Infection Diagnostics at the University of Basel, and he will talk about the Zika virus epidemics.
So, dear Reto, the organizers, thank you for having me. I'm the local speaker next to you, Reto. I don't work in Singapore. This is the title of my talk. I really would like to update you a little bit about Zika virus. I'm sure that you know most of it already because you follow the daily newspapers, and for the last 6 months this has been really a highlight. So this is the update from the WHO. Really 60 countries and territories report continuing mosquito-borne transmission of Zika virus, and 46 of them actually ongoing since 2015, and 14 actually have ongoing Zika transmission for the last almost 10 years. So this is really a virus that is transmitted and comes to stay. It will not be an easy task. There's also early and current evidence of person-to-person transmission without the virus, probably via the sexual route. There is the media attention regarding microcephaly, and we are all aware of these pictures that we have seen on television. And there's also other neurological syndromes which are not exactly explained by a cytopathic role or direct inflammatory role of the virus, most likely involving antibodies. This is the state of really confirmed cases. You see this is a high number of 1,581 cases, mostly in Brazil, but the number of suspected cases where the laboratory confirmation is missing is substantially higher. And you can see also, and this is concerning everybody else in the world, that these cases can actually be exported back home to places where they live in the Western world, for example, in Slovenia, in Spain, in the United States, or to Switzerland. This is the global map that you might be aware of. I'd like to highlight 3 issues. The red color is really the highest, the widespread ongoing transmission, and you can see that a more endemicity kind of pattern is seen here in the Southeast Asia, which actually meant that this has been under our radar. Zika has been ongoing in Asia for a longer time and actually spread from here to the different islands, from Malaysia to the Micronesia and Polynesian islands, and then came around to Brazil, and I will show you some molecular evidence regarding this. Another issue is very interesting. You can see here that in Cape Verde, right west of Western Africa, there's also activity, but again, it's the Asian strain, it's not the African strain. Actually showing that globalization, trade, and also transmission of viruses is ongoing and actually is ready for many surprises. So these are the questions. What is Zika virus? Why now? What are the do's and don'ts? And what's next? So really, what is Zika virus? I went back to the original paper that is often quoted, and it's actually very much fun to read. This is first-class virology back in 1947 at an institute that was at a road between Kampala and Entebbe, and outside of that place there was a little forest, which was the Zika forest, which they used in order to work on transmission of yellow fever. What they did is they put in sentinel macaques in order to identify those with fever and then look for viruses. And as an accident, they identified a virus that was not yellow fever, closely related, and this was actually this Zika virus, the first 766 strain, and you can see this viremic macaque, and they used the virus extracts to passage that in mice, and they made some interesting observations. There was a clear neurotropism for the mice, and the neurotropism actually worked best when you directly inoculated the virus into the brain, but not when you went into the peritoneal cavity, unless the mice were very, very young, meaning probably the blood-brain barrier played an important role in this transmission. So this is the summary, and I think this is first-class science, really. The isolation of what is believed to be a hitherto unrecorded virus is described, really a fact. The first isolation was in 1947, and we also could isolate the virus from Aedes, from a mosquito that was suspected in the local transmission. So this was actually a complete paper, and there were cross-neutralizing tests that indicate that Zika virus is not related to yellow fever, which is not exactly true, but if you use neutralization assays at a very high level, you can clearly distinguish these different flaviviruses from one another. So here you can see on the right the Flaviviridae. You can see that many of them are transmitted by vectors, mosquito-borne, Culex, for example. The paradigm here is West Nile virus or Japanese encephalitis, or Zika virus, very closely related to dengue virus, and it's vectored by Aedes species. Then we have the old world Aedes species, which is, for example, transmitting yellow fever virus. And down here we have tick-borne encephalitis virus, which is endemic in Europe, which is then transmitted by ticks. So these viruses are uniquely able to use vectors and then actually colonize different hosts, and we will get to that. Dengue, yellow fever, West Nile, Japanese encephalitis, tick-borne, and they all look the same electron microscopically. A single-stranded RNA covered with a membrane, and then a very typical surface structure, and I will get back to this when we talk about neutralizing antibodies. So the viral life cycle is only of limited interest to clinicians and maybe to nanomedicines, but I think it's important to realize that a single-stranded RNA is actually generating one polyprotein, very much as we know it for hepatitis C. And the drugs that have been developed so successfully for hepatitis C, it's very likely that some of them, or very similar ones, could be used also for other flaviviruses. So here you can see this polyprotein, how it's going up and down. The membrane down here is the cytosol, outside is the endoplasmic reticulum, and you can see that there is a really up and down with the E protein coming out and sticking out into the ER lumen, which is a major neutralizing target. The virus gets in, generates a replication complex in the cytoplasm, actually in as close association with the endoplasmic reticulum, and then is budding off, or is transported off the secretory pathway. And you can see that the shape changes as the virus is matured upon action of different proteases. There's also a viral protease, which is important for the non-structural protein, for the NS proteins, but all the other functions are actually done by host cell proteases. So you can see that there's a high degree of adaptation necessary in order to generate virus particles. Now, these are the landmarks that you are more or less familiar with through the daily press. Isolation, we've discussed that. 1952, exposure in humans was documented via antibodies. In 1954, first human cases in Nigeria, then a human volunteer experiment with fever, headache, joint pain, and mild jaundice, relating this to yellow fever. Then isolation from Aedes aegypti in Malaysia, sorry for the misspelling. Then human cases in Central Java. Then really not much happened, and this is why this is in the section on neglected diseases. Today we would not call this a neglected disease. This is an emerging disease, definitely not neglected anymore today. But there was very little going on until 2007, when in the Yap Islands, again in the Pacific, there were these transmissions. Then there was a case from Africa returning to Colorado, demonstrating the first male-to-female transmission that is published in 2007. And then we have these two outbreaks, first in French Polynesia and then in South America. And this is really, as of February of this year, the declaration of a public health emergency of international concern. So transmission we have discussed. There are some implications we have not discussed. What's the role for transfusion? What's the role for solid organ transplantation? So there are issues where we still need better diagnostics, regulatory issues. The manifestations, like many viral diseases, asymptomatic in 80%, a viral syndrome with fever, rash, headache, and conjunctivitis in about 20%, and that occurs 4 to 7 days after infection. And then there are outliers which are causing a lot of attention. And of course, if you have lots of people getting infected, then you also have these central neurological syndromes with encephalitis, myelitis, and calcifications, especially, of course, in the very young or in the infected fetus. Guillain-Barré syndrome, eye infections like uveitis. And please remember that the testicles and the eyes belong to the immunologically privileged organs. And there are cases also of Ebola virus, where survivors actually developed uveitis with infectious Ebola virus 8 to 9 months after they survived the acute infection. And of course, fetal microcephaly. Now here the association is very strong, and some people consider this now proven, and the question is really not so much what is the virus doing, this is of course very important, but whether there are cofactors that play a significant role. Here's some numbers: 16,000 babies, 2 to 8% microcephaly rate, 1,000-fold higher than expected. Then there are some caution, maybe in Colombia they could not identify the virus, there were also microcephaly, and this brings us to the differential. Really, microcephaly is an unspecific syndrome, and in the infectious diseases we talk about STORC, which is really syphilis, toxoplasmosis, rubella, cytomegalovirus, and herpes virus infections. Then there's toxic exposure. Alcohol, smoking, the most prevalent, but also heavy metals, arsenic, mercury, and radiation. Then there's genetic abnormalities like Down syndrome, that is of course clear to diagnose, and of course severe malnutrition during fetal life. So these are all cofactors, so not every case of microcephaly is really Zika, and that's why there's a strong emphasis on diagnostics. There are models now with animals, with mice in particular, where you can see that the placenta and especially the trophoblasts are being infected with Zika virus, and that there's a local innate immune response which is very prominent, looking at interferon lambda, and it's possible that also genetic markers, as has been identified for hepatitis C, may play a role in transmission to the fetus. So why now? Well, actually it has happened before. We know all this. West Nile virus, an old world virus, to North America in 1999, and in 5 yearly waves reached the West Coast, and many people got infected. We had all these dead birds, the problem with the horses, this you've heard in the last 10 years. Chikungunya around the Indian Ocean, and then autochthonous cases in Italy, in the Ravenna area, through an incubation time viremic person that visited friends and then reached local transmission. Then, of course, chikungunya spread to the Caribbean and the southern US, Central and South America. So we know. And then, of course, there's dengue, and dengue with all these different types that are mixing up and actually complicating the clinical outcomes. So what are the reasons? Well, I think the ingredients are a little bit like a cookbook. You have a virus that has cross-species infection. You have an RNA genome with a high mutation rate. There's a host that is permissive and relatively long-lived as a reservoir. You have a vector that is feeding on host 1 and then accidentally feeding on host 2, that could be humans, and maybe even adapting to host 2. And you have the same for the mosquito. The mosquito lives in the forest, and the other mosquitoes adapt to suburban and urban area. So this is the ingredients. And then you have a wonderful species of which there are plenty. You know, some people say 7 billion. They're non-immune, and they can actually replace reservoir 1. So variability, reservoir, transmission, and opportunity, these are the ingredients. And you can see there's an additional dynamic component, and I will come back to that in a moment. Genetic change, geographic change, behavioral change, climate change, not only because of warming, but also of more rainfall and opportunities to breed. Population increases, and this is the amplification epidemiology that is generated. Now, when we look at these more specifically at the sylvatic and the suburban-urban transmission cycle, we can see that it's nicely illustrated with different species with regard to the mosquito as much as to the primary host. And we can see that here the human may be an accident, maybe a dead-end host, but eventually we develop these suburban cycle, especially for the tiger mosquito, for albopictus. So where do we find these vectors? And what's still interesting that currently somehow there's a good relationship between Zika and Aedes aegypti, the yellow fever mosquito, and not so much with albopictus, but many people think that this is coming up very soon, given the flexibility of the virus and the adaptability to a new vector. And why is that important? Well, it's important because albopictus is the one that is urban and suburban, and that's why you have a high risk here in the southeast of the United States, and again, the same areas in Brazil, but also here in Europe, and I will come back to that a little bit later. So basically what I told you so far is really here in this map, out of Africa, established itself in Asia, and then moving around the world as globalization and trade and rapid air travel is increasing. We know these ingredients, so it will happen again. So what do we know about the viral species? And there's a very interesting paper that was published in Science, and there's a lot of high-scale papers right now where the epidemiologic curve here, and the number of cases was very much linked to the summer here. They could link it to specific regions in the northeast of Brazil, and you can see these red dots where also microcephaly cases were identified, and the genomes were compared by sequencing, and they could generate a similarity, a molecular clock phylogeny, where clearly the Malaysian cases were down here, but here you can see cases from Brazil, cases from microcephaly, and from other American places, so they were all more or less in the same area. And if you look at the molecular clock and now associate that with mass gathering and with air travel, the conclusion of the authors was that this was not due to the World Cup in 2014. It was not via a canoeing event, but it was actually the Confederations Cup in 2013 that correlated best with these clades and their spread. So what you can also take from this map, that this virus is still dynamic, it's still adapting, it's not the same, it's not a static, it's a moving target. So what are the do's and don'ts? Well, the WHO response is a little bit like going to church. You know, they say a lot and they want to help a lot, but it doesn't really boil down to action unless you really take them by the hand. And I think this meeting here is an opportunity to actually make them, you know, pay for their words. You know, they really say you have to, you know, talk closely to the affected countries, make sure that nobody gets the virus, especially the people at risk, the women at childbearing age. So these are all good words. Let's go a little bit more specific. What do we do in Switzerland right now? So obviously you seek travel advice, you know, you want to know about the epidemiologic situation, how can you prevent from mosquito bites, because there are many, many agents that are being transmitted by mosquitoes. But really the most important one is, if you are a pregnant woman or you are planning a pregnancy, you should actually avoid traveling. This is a very severe recommendation, and it shows how helpless we are. And now if you transpose that recommendation to the local area where people are recommended not to become pregnant anymore for how much time? 2 years, 5 years? You know, these are the issues that are really, really challenging and require urgent attention. Let's move on to therapy and prevention. Usually that is something that is covered already before. Don't get bitten by a mosquito. I will not go into much detail because we want to save a little bit of time now. But let's come to this one particular case that is extremely well documented. This is a Finnish lady that traveled together with her husband in Central America and went back home to Washington, D.C., where she was a resident at the time, and she developed, after return, a typical rash, and at this time she was found to be pregnant, and the fetal head size was normal on ultrasonography. Then she developed a fever. Actually, she went home over Christmas to Finland, and they found that there was actually IgM for Zika virus and IgE, and they also found it to be Zika RNA positive. So this is worst case scenario. So at this point in time, the fetal head size was normal. And as they moved along, they got the serum samples from the United States, and it was still confirmed. And as you can see here, then at the 20th week of gestation, there was significant malformation seen, and also the corpus callosum was very small, something that one could also reproduce in mouse experiments. And at this point, the pregnancy was terminated, and provided the painful opportunity to actually look at all these different tissues now from the fetus, and actually also the virus could be cultured. So the story, and this is so convincing that, you know, it stands representative to all the other cases that were identified by an epidemiological association. And you can see that the pathology was very carefully defined here, and all the way down to the ultrastructural features, also including viral particles that are in agreement with flaviviruses. Now, there is a lot of research going on, and I think also for this meeting it's important that one is tapping into this knowledge, because the opportunities where to interfere probably require some sophistication. Here's an animal model from the people that have published this work, where you can see clearly that the infected one develops a smaller brain size. You can relate that to specific subanatomic structures, specific cell layers, and you can see also a viral dose and an inoculum effect, and you can do all the modern technologies with expression profiling to identify really what is the response of the host and which ones of these responses are beneficial and which ones are more associated with disease. Now let's turn back to the laboratory. You've seen that there were a number of tests done, and this is what we do here in Basel. Really, the molecular testing, and we've heard that in this earlier talk, that is really convincing. However, this works only during the first week of symptoms, and you might actually miss it. So if you have a positive PCR for Zika, that's very good, but if it's negative, it's still open. It could be dengue, or it could be chikungunya because of the overlapping epidemiology and also clinical presentation, or it could be actually just a little bit later in the Zika virus infection, and here we come to the antibody testing. Now, the antibody testing has a problem with cross-reactivity, and here the IgM are very, very important, and if they are positive, they need to be confirmed. So an important message from all these studies was we can not only use plasma and blood products, but we can also use urine, where we have a little bit more extended detection of the virus. And of course, amniotic fluid, anterior chamber fluids biopsy, and of course, postmortem. So whenever one should target the molecular testing, and the antibody is really a helper, a secondary helper, and it requires a lot more expertise. This just shows you the cross-reactivity that you can see, for example, in a chikungunya patient or with a negative control here, and here you can see a patient with dengue response. You can see that the highest titer, if the light was off, you could probably see it better. The highest titer was to dengue 3, but there's a significant cross-reactivity also for Zika virus. So really one has to be very, very careful and do a lot of laboratory studies. Fortunately, there is now a specific ELISA available that seems to work very well across a number of related viruses, or also those that are in the differential diagnosis, and, which is important, they work also quite well for IgM. So this is what we offer right now, the PCR combo for all 3 viruses, as well as the specific Zika virus ELISA test. Let me come to a close. These are 3 slides, so what's next? I think one of the biggest challenges has to do with the control of Aedes mosquitoes, or with the immigration into Europe. On the left, you can see Albopictus in red, where it's established, in yellow, where it has been introduced. You can see these are the nice zones around the Mediterranean, and the green ones where it's still absent. So this one, Aegypti, is really the one that is right now transporting Zika, is only found on the eastern coast of the Black Sea. But that can change. It either can change because now Albopictus is able to transmit this virus, Zika virus, or because Aedes is moving into our geographic area. What's next? Prevention by transmission via vector control. That's reducing, but probably not completely reverting or abolishing exposure. And I think the experience from Indochina and Thailand and Indonesia tells us that this will be ongoing, so it will not be perfect. It's important, but it will not be perfect. Protect vulnerable populations, such as pregnant women. That's important. We need to know that there are also asymptomatic causes and persistent infection in certain body sizes, especially sexual transmission. That's a complicated situation. Vaccine development, very important. There are recombinants of yellow fever vaccines that is very successful. These are thinkable and can be done. However, they're life attenuated. This is nothing you want to give during pregnancy or before pregnancy. These are difficult issues. They need to be dealt with carefully. What about antibody disease enhancement? An important issue. Neutralizing antibodies, pre or post-exposure prophylaxis. I think there is a lot to gain from this, but again, what about the efficacy in these immunologically privileged sites in the eye or in the male genital tract? Will they ever get there, and what will they cause there? So there are many issues. Antivirals, I think this is definitely the way to go with respect to hepatitis C. We have good examples, but again, there might be adverse events, and can we give them in pregnancy? So we see that this problem really needs multi-targeted approaches. And clinical studies and licensing, they will require at least 2 to 4 years. I will skip this slide, and I will just come to a last slide because time is up. And just to show you some encouraging data on the conserved epitope interaction, where among these viruses, especially the dengue virus, you can see these E proteins that have been in this more relaxed, immature, and this is the mature association. And here one has neutralizing antibodies that are now neutralizing dengue 2 as much as Zika virus, and one knows exactly where the antibody is binding, and one knows the footprint on the E protein. So these are very encouraging results, and either this epitope could be used as a vaccine, or the neutralizing antibodies could be used for pre- and post-exposure prophylaxis. And with this, I'd like to thank you for your attention.
Thank you very much for this comprehensive overview. It was really, I think, what we were looking for.